Okay, wow, thanks for that introduction. I now have 2 minutes for my talk, so we'll speed through. But you know about me, so that's great. Hi, thank you so much. It's an honor to be invited to speak here. Yeah, great. Here are my disclosures. Okay, so today we're obviously talking about hepatitis C elimination, in particular, how to reach the twin elimination goals of reducing new infections of hepatitis C and deaths related to hepatitis C by 2030. And modeling was one of the pieces of information that informed the development of these targets, but I think what's really important to remember is that what each setting and country will need in order to achieve these targets is going to vary depending on their local epidemiology. And I think this was shown really nicely in a paper we just published that was led by Adam Trickey at University of Bristol, where he developed a dynamic transmission model at a country level, which incorporated IDU-related transmission as well as community transmission, and looked at 88 countries, I believe, worldwide. And the model was used to estimate the contribution of injecting drug use to ongoing hepatitis C epidemics. So globally, it was estimated that about approximately 43% of hepatitis C transmission from 2018 to 2030 could be attributable to injection drug use. But as you can see on the right-hand side of this slide, it was highly heterogeneous, with the proportion of new infections due to injecting drug use very, very, very high in high-income countries, 80, 90, or even 100%. Whereas there was less contribution in low-income countries. And I think the take-home point of this slide is that, hepatitis C among people who inject drugs is an urgent problem worldwide, but countries are going to differ in their strategies in terms of how much they need to focus on this population to achieve elimination. And so today I wanted to talk about two specific interesting points that I think have really come out from the modeling in terms of thinking about how we address hepatitis C among people who inject drugs, and in particular, how we think about the broader benefits of these strategies in terms of drug user health. So I'll talk a little bit about harm reduction and the multiple benefits and the synergistic benefits of harm reduction. And then I'll talk I'll spend a little bit of time talking about stimulant injection and implications for hepatitis C. So Sarah Larney and Louise Dagenhart have done a great review which showed that the global coverage of harm reduction is incredibly poor. So there are major gaps in terms of harm reduction access globally. Only 4 countries where there's available data achieving high coverage of needle syringe programs and opiate substitution therapy for people who inject drugs. So this is a critical need. And I think the modeling has done a nice job of trying to re-emphasize the value of these harm reduction interventions. So this is a study in the US where we looked at 3 different settings, San Francisco, California, Scott County, Indiana, and Perry County, Kentucky. And Scott County and Perry County are kind of rural settings. They have increasing drug use epidemics, increasing hepatitis C incidence, whereas San Francisco is more of an established epidemic with high prevalence but kind of lower incidence. And the reason why I go into that is because when we looked at what kind of treatment scale-up would be required in order to achieve the hepatitis C elimination goals of reducing incidence among people who inject drugs, we could see that the treatment numbers differed across these different settings, and more treatment was needed in Perry County and Scott County because of the increasing incidence in those settings. So because of the emerging and growing epidemics, we would need more treatment in order to reduce incidence and drive incidence and prevalence down. But importantly, when we combine harm reduction scale-up with treatment, then the effects of harm reduction in terms of reducing hepatitis C transmission mean that we need fewer treatments in order to achieve our elimination goals. So for example, in Kentucky and Indiana, if we combine treatment scale-up with harm reduction scale-up, it halves the number of treatments we need in order to achieve elimination because they're preventing new infections, and harm reduction is also preventing reinfection in those settings. Now, we saw less impact in San Francisco because existing coverage of harm reduction was quite high there, so there wasn't as much room to scale up. So again, heterogeneity in that response. And some other modeling work that we've done has also shown that this combination harm reduction approach is not only more effective, but more cost-effective than just single intervention approaches for elimination. And so it's really the best bang for your buck and the best way to spend your money in order to reach elimination. And so Sarah Larney and Louise Duggenhart have followed that great work up with a recent paper in The Lancet, which was looking at the multiple benefits of opiate agonist therapy. And I know you can't read this huge table, but what it's trying to show you is the sort of review level evidence of OAT on reducing these harms among people who inject drugs. So the review found that OAT reduces hepatitis C, reduces HIV, improves antiretroviral treatment, both uptake and adherence, as well as retention to care, reduces criminal activity, and reduces mortality due to overdose, suicide, as well as other injury. So we have this huge list of benefits of opiate agonist therapy that we're now starting to pull into the models to try to get a sense of what are the broader benefits of these harm reduction strategies. And so this was work in that same paper led by Jack Stone at the University of Bristol, where he used all of some of those associations and fed them into a dynamic model of HIV and hepatitis C transmission, as well as mortality among people currently and formerly injecting drugs, and was able to show across 3 different settings, Kentucky, Kiev, and Tehran, the impact of scaling up opiate substitution therapy to 40% coverage. So these different lines show you the different bars on this chart show you the impact of scaling up. Scenario A is 40% OAT. Scenario B is 40% OAT with extended duration on OAT. And then the final scenario on the very right is 40% OAT, extended duration, as well as scaling up OAT in prison. The other scenarios are just in the community. And so broadly speaking, of course, you can see that as you scale up OAT and improve retention both across the community and prison, you get more impact on mortality, which is what's shown on the y-axis. But what's quite interesting is that the different shaded parts of the bars are the effect on different mortality due to different causes. So red is hepatitis C virus, and you can see that, and green is HIV. And so you can see that scaling up OAT has quite a large effect on averting HIV in the green, both in Kiev and Tehran on the middle and right-hand side of the slide, because they have quite a lot of HIV among people who inject drugs, whereas there's no HIV in rural Appalachian Kentucky, and so there's more impact on things like hepatitis C virus in that setting. Overall, though, you can see that there's substantial impact on overdose mortality as well. And so basically the take-home point of this slide is here we have all of these multiple benefits of opiate agonist therapy in total preventing over a quarter of deaths in Tehran, for example, on the right-hand side of the slide. So substantial impact of scaling up opiate agonist therapy in this population. And we sort of wanted to build on that work to really look at this idea of if there are potential synergies with scaling up harm reduction. So we know that opiate agonist therapy, as I mentioned, directly reduces HIV and hepatitis C transmission, but there's an interesting synergy that happens as well. So antiretroviral therapy for HIV reduces HIV transmission, as we know. Opiate agonist therapy also reduces HIV transmission. But OAT also, as I mentioned, increases uptake and adherence and retention onto ART. So you can imagine that if we scale up OAT and ART at the same time, we could get these potential synergies where OAT actually further improves ART coverage from what it would have been just compared to scaling up ART alone, and you get this sort of synergistic benefit. And so this is a model that was done by Javier Cepeda at UCSD, and what we did was we were looking at HIV and overdose among people who inject drugs in Tijuana, Mexico, which is right across the border from San Diego. And we were looking at trying to find these synergies with integrated care. And so this slide shows you the proportion of new HIV cases that would be averted over 10 years if we scale up OAT alone, ART alone, and then the two. And so the very first bar, in this setting in Tijuana, there's actually virtually no coverage of OAT at all, and less than 5% of people who inject drugs are on ART. So very, very minimal coverage of harm reduction and HIV prevention interventions. And so if we scale up OAT, but we only include the benefits of OAT on ART adherence and improvement and retention, we basically get no infections averted. There's no impact because there's no ART, very little ART there to kind of synergize with to boost those benefits. And in fact, if we scale up OAT to 40% coverage, the the predominant benefit that is observed is due to its direct effect on preventing HIV transmission. Okay, so most of the effect that you see, and it's quite a substantial effect, preventing about 40% of new HIV cases over 10 years, is just because of its direct effects, because there is no ART to synergize with. Conversely, if we just scaled up ART recruitment by tenfold, which would sort of achieve a level of coverage that is similar to the general population in Mexico, about 60% ART coverage, then we could reduce new HIV infections by about 25% in 10 years. But if we scale up the two of them in an integrated fashion, and we're just, again, we're just simulating the synergistic benefits of OAT on ART recruitment and retention, you can see that we get more of a benefit. So with OAT alone, just with the ART benefits, on the very left-hand side, we got no impact. But now we're providing, in the yellow, we're providing ART scale-up, and then the green, we're providing OAT just with those synergistic benefits. And you can see you get a bigger bump. You get this kind of synergistic improvement. And if we do those things, sorry, so that's showing that. And then if we incorporate all the benefits of OAT on not just ART, but HIV transmission and reincarceration, then we could prevent over half of new HIV infections in the next decade. So a substantial combination, synergistic effect with these two interventions together. And finally, unfortunately, what has actually happened in Tijuana is that the federal government has provided funding not for opiate agonist therapy, but for compulsory abstinence programs, which in our studies have been associated with increased HIV risk as well as fatal overdose. And so in Mexico, we simulated the impact of scaling up of those programs as federally funded, and we could see that that could actually cause more HIV in the next 10 years, really underscoring the importance of federal funding for these evidence-based strategies. And so just to sort of tease out that synergistic point that I was mentioning before, if we look at just the number of new infections that are averted through that synergistic effect, again, of recruitment and retention onto ART through opiate agonist therapy, without any ART scale up on the left-hand side, we get only about 2 or 3% infections averted over 10 years. Whereas with ART scale up, we get 10 to 12% infections over 12 years. So this really highlights, I think, the synergistic benefits of these interventions together. And of course, I've just been talking about HIV and OAT, but I think as we're moving forward, we're continuing to think about trying to highlight these potential synergies with other diseases, and can we find these synergies with harm reduction and hepatitis C to really further emphasize the point that harm reduction is a critical component to our hepatitis C response. Okay, and finally, I'll just take a moment to talk about stimulant injection. In a recent paper that we published in The Lancet, there was a global review about stimulant use and injection. We know that the manufacturing and seizures of stimulants has increased 20% from 2015 just to 2016, so it's a growing problem globally. Among people who inject drugs, it's quite heterogeneous in terms of the prevalence who inject stimulants, about 20% in Western Europe, exceeding 60% in some Asian settings. It's about 40 to 50% here in North America. And what this review found was that stimulant injection, both cocaine injection as well as amphetamine injection, among people who inject drugs are associated with about a 2 to 3-fold greater risk of incident HIV and prevalent hepatitis C compared to people who do not inject stimulants as their primary drug. So there's clearly increased risk. We have studies that show that there's both increase in sexual risk in terms of number of partners and condom usage, as well as injecting risk in terms of frequency of sharing. Unfortunately, we have no effective pharmacotherapy for stimulant injection, and psychosocial therapies currently have weak or non-specific effects. So there's really a gap in harm reduction for this particular group. And what we wanted to do is we wanted to take these observed statistical associations in terms of stimulant injection for HIV and hepatitis C and see what they meant in a few general characteristic settings or scenarios, I would say, to quantify the potential contribution of stimulant injection to ongoing epidemics. And we did this, again, this is work led by Javier Cepeda at UCSD. We did this, and again, we picked 3 kind of scenario-based settings. So a low, a medium, and a high setting of prevalence of stimulant injection. So for example, in St. Petersburg, approximately 15% of people who inject drugs inject amphetamines, an amphetamine-type substance. In Montreal, about 35% of people who inject drugs inject cocaine. And in Bangkok, about 65% of people who inject drugs inject methamphetamine. And so we just wanted, these were really scenario-based, but we were trying to pick kind of, all right, in a low, medium, and high prevalence setting of cocaine or stimulant injection, what was the excess burden of hepatitis C and HIV in these populations? And we found that this is the proportion of new hepatitis C infections among stimulant injectors. So stimulant injectors have a disproportionate amount of new hepatitis C infections in the next year. We found the same thing for HIV. And if you look over the next year and estimate the proportion of new hepatitis C infections which could be attributable to the risks associated with stimulant injection, we could see that in a low prevalence setting like St. Petersburg, about 7 or 8% of new HCV infections could be attributable to the risks associated with stimulant injection. Whereas in Montreal and Bangkok-like scenarios where between 30 and 65% of the population injects stimulants, you could have as much as 20% of new hepatitis C infections attributable to stimulant use. And I think this is really important because it underscores that stimulant use could be a substantial driver of hepatitis C transmission, and we do not have effective interventions that can really combat this. So really calling for the need for investment of interventions to reduce stimulant injection. Okay, so overall, I think it's clear that people who inject drugs are an important group which are vulnerable to hepatitis C globally, but their contribution to their country-level epidemics varies and is highly heterogeneous. And so the strategies that we'll need in terms of global elimination will differ, but among people who inject drugs, we know that we have effective strategies to combat hepatitis C, both with harm reduction and with hepatitis C treatment. Unfortunately, the low coverage of harm reduction really remains an important barrier for hepatitis C elimination and prevention of harms among people who inject drugs. And I think the modeling is really trying to explore these numerous benefits of harm reduction and the synergies of integrated care in order to better kind of make the case to policymakers as to why harm reduction is such a critical part and should be scaled up globally. And finally, stimulant injection, I think, is an important consideration, especially in particular settings like here in Montreal, and really requires investment in treatment and prevention strategies. Finally, I'd like to acknowledge my collaborators. Thank you.